this is it. The first speaker is Dr. Salil Kumar Mandal, and his paper is on early division of cutler bed using tissue expander for bridge flap, PK for tarsus replacement. Is person there? Dr. Salil Kumar Mandal is here? Okay, sure. This is the session. इसको वापस डाल दूँगा. ये मैं देती हूँ.
Respected judges and my colleague here, my title is Early Division of a Cutler Beard using a tissue expander for breech flap and filamentous knitted polyester fabric for tarsus replacement. No financial interest. Upper lid reconstruction is always a challenge. Large defect involving 60 to 100% needs tarsal plate replacement and for architectural support. The cutler beard, a two-stage procedure, modified using a novel tissue expander by the balloon of 10-14 French silicone catheter. It recruits extra tissue from the skin and subcutaneous muscle complex for breech flap. Novel filamentous knitted polyester fabric as a suitable replacement for tarsal plate, allowing an early division at 2 weeks instead of 6 to 8 weeks. Purpose: to assess the safety outcome efficacy of early division of cutler beard at 2 weeks. Use of novel filamentous knitted polyester fabric in replacement of upper lid tarsal plate architectural support after resection of a large upper lid tumor to estimate the functional and aesthetic outcome. Prospective interventional study of the patient of 10 patients. Target is 30. Second stage of CV was done on 2 weeks. The created defect pre and post measurement, MRD1, PFH, LPS actions are noted. The balloon of 10-14 silicone Foley's catheter used as a novel expander device. In graded inflation for 3 days. On 4th day, the balloon is deflated and the cutler beard procedure done. Baseline Doppler flowmetry at marked area after short duration of tissue expansion. Again, deflation. Again, do Doppler flowmetry to assess the flap vascularity. Inclusion care, all upper eyelid malignant tumor, upper eyelid created defect. 100% involvement of local lymph node, exclusion criteria, distant metastasis, liver, lung, brain, associated lower eyelid involvement, gross corneal infiltration. Now comes to the video. This is an ellipsoid area which is marked the infraorbital area. Baseline Doppler flowmetry done to estimate the vascularity of that area. The balloon of the 14 French catheter graded inflation for 3 days. On 4th day, it deflects. That means a tissue is recruited there and tissue is large. Again, do a Doppler flowmetry for check the vascularity. Vascularity is increased. Cutler beard stage 1 done. This is an advancement flap, which is separated anterior posterior lamina. This separation is much easier when you do expansion of the tissue. Then filamentous knitted polyester fabric used as a tarsal plate replacement over the posterior lamina bay. It is fixed with a 5-row polygalactin and it is sandwiched with the anterior lamina. This is the after 14 days. After 2 weeks, we separate anterior posterior lamina. This is the post-op image of this patient. So MRD1 minus 1.80 to plus 466, pre-op PFH value 1.6 to 11.25, LPS action 1.5 to 14.5, and Doppler flowmetry study is pre-systolic velocity 6.98 to 10.90 millisecond, end diastolic velocity 2.36 to 3.6 second per millisecond, pulsatile index of 1.28 to 1.7, resistive index 0.6 to 10, number of vessel increase, diameter of the vessel increase, blood flow increase, easy separation anterior posterior lamina. All cases of elliptical filamentous knitted polyester fabric is used as a tarsal plate replacement in this study. Dimension is 28 mm length, 6 mm central wide with a multiple hole. It is flexible, pliable, inert, tissue friendly. Expansion of tissue in elliptical manner preoperatively recruit extra tissue for breech flap formation. That is why the early division is possible in 2 weeks. Good healing due to increased vascularity, proved by Doppler flowmetry, increased vascularity, the data shows. Cutler beard procedure, the stretching effect already done by balloon of the 10-14 French balloon. In cutler beard procedure, that is 6 weeks is not required for stretching effect. So comes to a conclusion, useful in one eye patient, tissue acceptance is excellent, no such graft failure infection, extrusion of the FKPF, overall architectural support of the lead is well maintained and excellent aesthetic appearance. Short duration, rapid expansion of the skin muscle complex shows the increased vascularity of the Doppler flow metric study. It causes extra tissue recruitment that helps in early division of breech flap and good healing of the wound. Thank you.
Thank you, Dr. Mandal. That was an excellent presentation, a very good, innovative technique. Tell me, so the time of leaving the tissue expander, was it the same for all the cases?
Yes, we have a tissue expansion in every day. When you start this study first, it is in 15 days. But 15 days, the tissue will not relax. It is become a fixed swelling. Then again reduced to a 7 days. It is relaxed, but it is long duration. You have a temporary deformity face that is not accepted by a patient. And in the hospital stay for 7 days is too long. So again, you reduce to 3 days. 3 days is optimum. We are doing this expansion for the last 4 years. Now, we applicable before that in tangible rotational flap and published in Indian Journal of Ophthalmology. Now, we did this theory for expansion of the tissue for breech flap formation for early division of cutler beard procedure. And it is success.
Okay. Sir, what will be the exclusion and inclusion criteria in your study?
That is given here in the slide. That is inclusion criteria is 60 to 100% defect. And gross corneal infiltration is exclusion criteria. Metastasis is exclusion criteria. This is all the cutler beard where the study is given here, yes. It is fully given here.
Okay. Were there any recurrences were there any recurrences in your cases since you've been doing it for 4 years?
No, yeah. One of the author is done in UK for 4 cases of early division of cutler beard procedure, but there has a complication of stretching effect because there is an entropy and ectopy develop because tissue is not stretched. The concept is that expansion of the tissue. In cutler beard, basically a tissue expansion. We are already done by the balloon of the 10 French 14 catheter before.
I'm
Then
just asking, in your cases, were there any recurrences of the primary tumor?
No. This we do margin control in every cases. Okay. So that is why in our study is not record till now. After 2 to 3 follow-up, then we can again see. This is a new study after doing 1 year. We are doing only 14 cases, 10 year, but 14 cases we have already done. Our target is 30.
Okay. And I'm presuming these are all upper lid tumors. You're doing the expansion in the lower lid.
In this study.
Yeah.
We can applicable the expander anywhere, except over the eyelid. Yeah. This expansion only for 4-dimensional, but the other expansion is 3-dimensional.
Okay. Thank you.
What is the cost of this tissue expander?
Hello?
What is the cost of this tissue expander?
Tissue expander, it's a balloon catheter.
So how much is
300 rupees.
And for every case you are using the new one or
300 rupees per case. This is available in the hospital.
Okay, thank you, doctor. Next one.
Now I invite the second speaker, Dr. Raguraj Hegde. He'll be presenting on outcomes of frontalis flap suspension technique for severe blepharotosis with poor levator function.
Dr. Hegde is here. Anybody from his team? Okay, we'll move on to the next. Maybe he's a little late. The next paper is Dr. Aditya Biswas. Evaluation of Muller's muscle conjunctival resection versus LPS plication in mild to moderate ptosis. Number 3 है, number 2 आए नहीं है. Okay. While we're waiting, I'll just check who else is present. Dr. Aparna Kurian is here. Okay, good. Then Dr. Suman Kumari Meena is here. Dr. Nipun Kumar. Dr. Nipun Kumar is here? No. Dr. Anmol Kar. Dr. Rath is here, I can see him. Dr. Samantha.
Compared to LPS plication in cases of mild to moderate ptosis. Ptosis is an abnormal low-lying upper lid margin in primary gaze. There are many classifications of ptosis. It is mainly graded into mild, moderate, and severe according to marginal reflex distance 1 or MRD1. It is the distance between the corneal reflex and the upper lid margin in primary gaze. Although there are multiple non-surgical and surgical modalities for the treatment of ptosis, our study hypothesis was to evaluate Muller's muscle conjunctival resection, which is more predominantly used for the treatment of mild ptosis, as compared to levator plication, which is more widely used for the treatment of moderate ptosis in terms of their functionality and cosmesis for the management of both mild and moderate ptosis. In our review of literature, we saw the following studies which concluded MMCR to be equally efficacious as external levator resection or advancement in mild to moderate ptosis cases. Additionally, Sweeney et al. Concluded that MMCR has superior results compared to ELR when phenylephrine test was positive. Nesse Arsenal et al. Concluded that MMCR group had lesser rate of complication and duration of surgery. Our aims of objective was to compare MMCR to levator plication in terms of their efficacy and cosmetic results in cases where phenylephrine test was positive, because there was a paucity of prospective studies for the same. Ours was a prospective comparative randomized interventional study. We had taken 20 patients of mild to moderate ptosis, unilateral with good LPS action and phenylephrine test positive, in consenting patients more than 4 years of age. 20 such cases were taken and randomized into 2 groups. We had done their preoperative evaluation followed by surgery. Postoperatively, they were followed up on 3rd day, 10th day, at the end of 1st month and 3rd month. In preoperative evaluation, we had taken their history, general examination with ocular examination, finally ptosis workup, after which the patient underwent under either MMCR or levator plication. In post-operative assessment, we had graded them according to 3 criteria: the marginal reflex distance 1, objective assessment of cosmesis based on MRD1, and subjective assessment based on patient satisfaction scale. In results, we saw the mean age of presentation was 18.15 years, male is to female ratio was 1.22, right eye and moderate ptosis were more often operated than their counterparts. In levator plication group, the baseline preoperative MRD1 was 1.5, which improved to 3.7 after 3 months. And in the MMCR group was 1.3 mm, which improved to 3.8 after 3 months. The p-value was insignificant. The 3rd month MRD1 following surgery had statistically insignificant p-value. The objective assessment had 100% good grade, and the subgroup analysis showed the same with insignificant p-value. In subjective satisfaction, also had insignificant p-value. This was a case of MMCR. Post-operatively, the MRD1 improved with no surgical scar. This was a case of levator plication. Post-operatively, after day 10, we saw improvement in MRD1 with a surgical scar. Therefore, to summarize, there is no statistical difference in MRD1 objective assessment or subjective satisfaction in a study between both groups. We also saw no ocular or cosmetic complications in both groups after 3 months. We conclude MMCR is a safe and effective modality as compared to levator plication in cases of mild to moderate ptosis with phenylephrine test positive, and recommend it for such cases because MMCR is a transconjunctival procedure and leaves no scar as compared to levator plication, which is an external procedure and will leave a scar. Thank you.
Thank you, Dr. Biswas. So all your cases were phenylephrine positive?
Yes, ma'am.
And you didn't grade like mild and moderate, it was just mixed.
Yes,
It
ma'am.
was randomized.
It was randomized. All were phenylephrine positive, and then we randomized into 2 groups.
So do you feel 3 months is enough to assess, the efficacy of the procedures?
Yes, ma'am. That is one of our drawbacks of our study. We had recommended a larger sample size with a longer follow-up for better assessment of this between the surgeries.
And did any of the cases need any secondary intervention?
Up until 3 months, there was no need of a secondary intervention.
Just a suggestion, for the larger screen it was okay, but for the screen, the font size should be at least minimum 24. We had a tough time reading few of your papers.
Okay, so yes, ma'am. Thank you. I will note it next time.
Okay, from my side, like Mueller muscle resection or conjunctival muscle resection is effective most of the time only for mild cases of ptosis. Okay, so you can't compare like mild to moderate, like both the entities you can't include in your study group. Either you can include the mild type of ptosis or moderate. Okay, for the moderate and severe, the plication or resection is more effective.
Ma'am, we had done subgroup
So
analysis
this is
for
a
the same.
limitation of your study. So you should have included like
No, she's done it.
Ma'am,
Tell.
we have done subgroup analysis for the same.
What is the analysis in the moderate?
Ma'am, in the moderate group also, in objective assessment, it is 100% good grade in MMCR, and in also in subjective satisfaction for MMCR group, we had seen 50% had fair grade and 50% had good grade.
And what was the maximum amount of ptosis that you used in your study?
Ma'am, moderate 3 mm.
Okay, thank you, doctor.
Thank you, ma'am.
now I call the next speaker, Dr. Aparna. She's there. She'll be speaking on incidence, clinicopathological analysis, and surgical outcomes of various malignant eyelid lesions.
Ma'am, shall I start, ma'am?
Yes, please.
Yeah.
We're waiting for you.
Good afternoon, everyone. My topic is on incidence, clinical pathological analysis, and surgical outcome of various malignant eyelid lesions. So, as we all know, the eyelid skin and appendages, they are known to undergo many lesions. Among those involve the neoplastic lesions. This study was done in a tertiary eye care center to assess the incidence of each type of lid malignancy, their demographic details, pathological correlations, surgical modality, and outcome. So the most common lid malignancy reported worldwide is basal cell carcinoma. However, the studies conducted in Asian populations show the common lid malignancy to be sebaceous cell carcinoma. The causes attributing to lid tumors are old age, sunlight exposure, radiation exposure, genetics, smoking, etc. Earlier surgical intervention with wide margin excision of the lid tumor and accurate histopathological diagnosis are key steps in the management. Coming to the methodology, this study is a retrospective analysis of histopathologically proven 100 patients with lid malignancy done during the time period of 2022 to 2024. The most common symptom with which the patient presented was swelling of the lid, and imaging were advised to those patients in whom the posterior extent of the tumor was not accessible, and those with signs such as deviation of the eye, restricted extraocular movements, etc. The patient was subjected to a wide margin excision biopsy. Tissues were sent for histopathological analysis. Once the surgical margins were confirmed to be tumor-free, lid reconstruction to close the defect was planned. Permanent section takes around 10 to 14 days to report the final diagnosis. The parameters assessed in the study were the type of lid malignancy, age, sex, site of the lesion, local or distant spread, recurrence, and the need for adjuvant therapy. So first is a 63-year-old female with right eye lower lid showing a tumor which was confirmed to be surgical free margin, and later the lid reconstruction was done. And the histopathological picture shows a characteristic nest of basal cells with peripheral palisading appearance, characteristics of basal cell carcinoma. This is a patient, 50-year-old patient with right eye showing squamous cell carcinoma with a histopathology showing squamous cells with eosinophilic cytoplasm. This is a 70-year-old male patient showing left eye upper lid tumor with a characteristic yellowish discoloration showing fat deposition and a fleshy mass. Histopathology showing sebaceous gland carcinoma with evacuated cytoplasmic cells. A total of 100 patients were included in the study. The mean age of the participants was 65 years and it ranged between 88 to 95 years. There were 47 males and 53 females. Right eye was involved in 48 cases, left in 51 cases, and one patient with xeroderma pigmentosa had a bilateral involvement. The lower eyelid was more commonly involved than the upper eyelid. So coming to the result, in our setup, we saw the most common lid malignancy to be sebaceous gland carcinoma, which was 53%, followed by basal cell carcinoma, which is 24%, followed by squamous cell carcinoma, which is 15%, and the less frequently seen cases were the poorly differentiated carcinomas, malignant melanoma, and the patient with the bilateral carcinoma had a basal cell carcinoma in the right eye and squamous cell carcinoma in the left eye. Tumor-free surgical margins were obtained in all the patients. Lid reconstruction was done in all patients, and all the patients were followed up after 15 days and 4 months. And in our study, the four cases of sebaceous gland carcinoma and 2 cases of squamous cell carcinoma showed local metastasis, and 1 case of squamous cell carcinoma showed a distant metastasis. The patient with the bilateral lid tumor also showed local spread of the tumor. All cases of the metastasis received adjuvant therapy in the form of radiation. 1 case of squamous cell carcinoma with local metastasis had to undergo excision. So 4 cases of sebaceous gland carcinoma and 2 cases of squamous cell carcinoma had local spread, and 1 case of squamous cell carcinoma had a distant spread. And among the cases, 1 case of sebaceous gland carcinoma, 4 cases of squamous cell carcinoma showed recurrence. So comparing to the other studies done in Indian setups such as Kalki et al., Gupta et al., Banerjee et al., Sihota et al., and Kadir et al., sebaceous gland carcinoma was the most common lid malignancy encountered. Other studies, few studies in Indian setups such as Jahadir et al., Kale et al. Showed basal cell carcinoma as the most common lid malignancy, while the studies conducted in abroad such as Switzerland, Japan, China, Taiwan, and Singapore, they equivocally showed basal cell carcinoma as the most common lid malignancy. This study was compared to the other Indian study like Kalki et al., Gupta et al., which showed the most common carcinoma to be sebaceous gland carcinoma. Even though these studies show sebaceous gland carcinoma as the most common carcinoma, they were not representative of a major population. However, Gupta et al. Did a multicentric and a multisonal study in India to give a better outlook of the epidemiology of the lid malignancy among the population of India. Hence, this prompts in adequate medical record keeping and a uniform zonal study in India to study the epidemiological characters of the lid malignancy. These are my references. Thank you.
Thank you, Doctor. So what new information have you got from your study?
Ma'am, there are a lot of studies did. Some say basal cell carcinoma, some say sebaceous gland carcinoma. This is one of the small study we did just to in one location. Now we want to broaden the study to involve at least the majority of the south part to see first of all which is a common, then we can come to a diagnosis at least what is the etiological characteristic that can prompt to such a diagnosis.
No, in India it is sebaceous cell carcinoma.
Yes,
it's
ma'am.
always been that. I mean,
Yes,
that's
ma'am.
nothing new.
Yes,
So
ma'am. But
any-
those studies have only localized a small population and done, ma'am. All the studies, a broader study would have given us a better diagnosis, ma'am. A better solution to which is the etiology. It's just an observational study, ma'am.
But okay, so so there's no new information as such. We reconfirmed what was already known.
Yes, ma'am. And we want to broaden the study to
And if you
include
broaden it,
to include a major population, at least south part first, followed by we want to include the whole of India, ma'am.
To have more impact, number of years you can keep increasing so that after 5-10 years, if you report the same study.
That's what, ma'am. If you have an adequate record keeping, like how this is a retrospective study I did during the time period of 2022 to 2024. So if you have an adequate record keeping, at least in a 5-year period, we can go back and we can see which is the common and which has a characteristic etiology, pathology.
so the commonest is going to remain probably the same, but the other parts that you had in
Yes,
your
ma'am.
study, like
Yes,
the ones, the metastasis, local metastasis,
ma'am.
distance metastasis.
Yes, ma'am.
So this would be relevant, no?
Yes,
We need to, every study must have some bearing going forward
Yes,
so that we can help ourselves diagnose earlier. So I think we should focus more on which were the kind of cases in which you got the local, was there any difference in their histopathology? So that might be something better to focus on so that your study is more relevant.
Yes, ma'am.
Just increasing the numbers, we'll still find sebaceous cell
We
in our
included the
population.
recurrence metastasis factors also into account, ma'am.
Yeah, so when you expand your study, this is what is going to be more relevant, that which are the kind of cases where there is metastasis, should we be treating them differently, should we be treating them earlier, more neoadjuvant, should we start? So this is what you should be looking
Yes.
going forward.
Thank you.
Did you recommend systemic chemotherapy in any one of your
That one of
patients?
the squamous cell carcinoma showed a distant spread, ma'am, to a supraclavicular lymph node. For him, we had given a systemic chemotherapy. Rest of the patients underwent systemic screening. Nobody has shown any metastasis to any organs, ma'am. There's one patient only we saw, ma'am.
And how many patients received radiation post-excision in your study?
The 4 cases which had the local metastasis and the recurrence, ma'am.
So did they get the radiation following the surgery?
Yes, ma'am. They did, ma'am. Yes, ma'am.
Okay, thank you, doctor.
Thank you.
Next, we'll call Dr. Suman Kumari Meena. She is presenting congenital eyelid eversion, the quandary of whether to delay intervention.
Thank you so much. I would like to thank APO for this opportunity. I'll be presenting this interesting case where an infant came to us with congenital upper eyelid eversion. I'll be taking you through this in 4 segments. So this 8-day-old child came to us, bought by his father and grandmother, with a complaint of bilateral upper eyelid eversion, which was present at birth. He was born at 34 weeks of gestation by normal vaginal delivery, and the antenatal period was otherwise uneventful. Antenatal scans did not show any trisomy of 21. The only thing identified was oligohydramnios at 32 weeks of gestation. He was referred from Kota, Rajasthan with topical lubricants and antibiotic drops. So on examination, there was no dysmorphic feature and pediatric evaluation suggested no systemic abnormality. Coming to local examination, we could see that both the eyelids are reverted with severe chemosis and serosanguinous discharge with cresting. There was no anterior lamellar shortening. Rest of the anterior segment and posterior segment examination was within normal limit. So now the options were whether to manage conservatively or consider surgical intervention based on the amount of chemosis. The options for conservative management were lubricant, antibiotic, and saline so gauze application, whether we use normal or hypertonic. In surgical, the options were to mechanically reposition it, do temporary tarsorrhaphy, or apply compression suture or skin grafting. So how we manage this child is we used paraffin gauze and we used ointment, hydroxypropyl methylcellulose, chloramphenicol, and hypertonic saline ointment. Along with this, we added cold compression and we did a upper lid massage from above downward. So the treatment response was that child started showing response by day 3 of life, and by day 9 we could see there was a significant reduction in the amount of chemosis. So we discharged the patient on day 9 of starting the treatment and asked to follow after 1 week. At day 16 we could see that on conservative management, left eye has completely improved and right eye, while opening his eyes, the chemosis has reduced. When he was crying, the eversion was coming, but otherwise he was able to open his eyes. So at 1 year follow-up, we can see there is complete resolution of the upper eyelid edema. Since the patient was from Kota, he couldn't come for follow-up, so we just contacted him on telephone. Coming to the discussion part, on PubMed search, I could find 54 results with the first very report in 1896 reported by Adam. Since then, 54 reports are present, and it is frequently found in association with Down syndrome, with 15 patients being reported. The other associations identified as collodion skin disease, which is a ichthyosis, and it is more frequently found in Nigerian population. The proposed hypothesis is whenever there is a prolonged or obstructed labor, it causes eyelid eversion and thus lead to orbicularis spasm, which acts as a sphincter, which causes strangulation of conjunctiva and edema. This strangulation causes venous stasis and thus further chemosis and conjunctival prolapse and creates a vicious cycle of continued eversion, sphincter, further spasm and venous stasis. So all the reports which I went through, I found that majority of the patients were managed conservatively, and the aim of management was to prevent conjunctival desiccation and infection by using lubricants and antibiotics. Along with that, reducing the edema early by saline soaked gauze and over the prolapsed conjunctiva. Only very few required surgical intervention where even manual reposition on day one mostly failed. It was only successful when it was slightly reduced with topical lubricants and saline soaked gauze paste. Some had also tried subconjunctival hyaluronic injection. So the take home message is that the goal of treatment should be that you prevent the conjunctival injury by preventing the desiccation, and for most of the patients, wait and watch, consider conservative management and consider surgical intervention only if they are non-responders or there is chronic edema present. Thank you very much.
Thank you, doctor. That was well managed in the end. But tell me, up till how long would you have waited? You waited for 9 days and then discharged.
Yes, ma'am.
How long would you have waited? Was there any end point in your mind when you would say, "Okay, now we have to intervene"?
Ma'am, actually, whatever reports I went through in that, in the earlier days, what they used, probably because of the amount, we think that intervention will definitely help faster. So people who did compression sutures or lid sutures, the result came within 2 days of doing the compression. But with conservative management, the response came within a week, but by the time complete resolution happened, it was 4 weeks time. So based on all the literature study, I suggest that if the response has started within 1 to 10 days, it is good that we manage the child conservatively and wait for 4 to 5 weeks. If there is no response by 2 weeks, then we should consider surgical intervention in the form of temporary tarsorrhaphy or hyaluronidase injection or compression suture.
I have one suggestion, like before concluding, like when to intervene surgically, you should have whatever you have recommended in one case, you should have series of cases. And then only you can recommend like how long you should wait for surgical intervention
yes,
and all that. Based on a single case, you can't recommend anything.
Yes, ma'am.
That is suggestion
I
from
was
my
asking
side.
her, in her case, how long would she have waited?
Ma'am, since the response came within like 3 days of starting the treatment, so we continued the conservative management. Probably even we would have waited for another 10 days before we did any intervention.
And are there any, in your reports, are there any cases where waiting too long caused any problem for the
Ma'am,
child?
there was only one report where there was actually in that patient, child had corneal ulcer because of the eversion, and their therapeutic PK was done.
Yeah, but you see, in your case, if you
Yes,
don't do even an EUA, there is no way you can see the cornea.
Ma'am, we did a
You did see.
examination by DEMAS if we, because that prolapsed conjunctiva is actually helping
Yeah,
to
it's
cause
covering the
damage.
cornea.
It's covering the cornea, and if we retract it with DEMAS, we are able to see the
Yeah,
cornea
so you need
very
to highlight
clearly.
that
Yes,
you need
ma'am.
to make sure the cornea is okay.
Yes,
and then
ma'am.
if a week, 2 weeks, 3 weeks, then
Yes,
it doesn't
ma'am.
matter so
Yes,
much.
ma'am.
No? So that is the point why, when to intervene.
Yes, ma'am.
And I think other than managing anxious parents and grandparents,
Yes, ma'am.
if the cornea is okay, you
Yes,
can
ma'am.
do. Okay, thank you, doctor.
Okay, thank you very much.
Is Dr. Nipun Kumar here? Dr. Nipun? So the next speaker is Dr. Anmol Kar. A large hanging eyelid angiofibroma with associated rhinosporidiosis, an unusual presentation.
Good afternoon, everyone. Today I'll report a case of a large hanging eyelid angiofibroma with associated rhinosporidiosis and unusual presentation. A 34 years old male presented with slowly progressive, large hanging mass of 5 years duration, extending from left eyelid and reaching the chest region, associated with dragging sensation, diminution of vision, severe functional and cosmetic deformity. There was no history of prior trauma or surgery. On examination, the left eyelid hanging globular mass was noted, which was formed non-tender, measuring 15 cross 15 cm in diameter, with attachment of skin and soft tissue of length 10 cm. Overlying skin showed PUD orange appearance with few ulcerated points over the dependent areas. The conjunctiva was keratinized due to exposure. Rest of the anterior and posterior segments were within normal limit of both the eyes. The best corrected visual acuity in right eye was 6/6, while in left eye was counting finger at 2 meter. There was no preauricular lymphadenopathy noted. On imaging, there was a well-defined heterogeneously enhancing mass lesion with non-enhancing cystic spaces of size 9.5 cross 8 cross 11.5 cm with no intraorbital or intracranial extension. On angiography, there was confirmed arterial feeders from left external carotid artery, while dominant venous drainage to dilated superior ophthalmic vein. Wide excision followed by reconstruction was planned, maintaining a healthy margin of 5 mm around the tumor base. Intraoperatively, hugely dilated superior ophthalmic vessels were noted, which was ligated carefully and cauterized. Reconstruction was done with upper lid myocutaneous advancement flap. The nasal rhinosporidiosis. 3 months after surgical debulking, the patient had a good recovery of vision and anatomical function. The patient was planned for ptosis correction and lower eyelid fornix formation in the next phase. Angiofibroma of eyelid and its histological variants are sparsely discussed in the literature. The close differential of the current case can be the giant cell angiofibroma and the fibroblastoma. However, the absence of giant cell and CD31 and 34 positivity were the differential features. Charles et al. Has described a supraciliary lesion of left upper eyelid and immunohistochemistry confirms CD34, CD163 and factor 13A positive cells. Das et al. Have also reported a rare case of extragenital cellular angiofibroma which showed CD34 positive giant cells. A definitive link between angiofibroma and rhinosporidiosis has not been established, but our case indicates a possible connection. It is important to acknowledge the rare possible overlap of these conditions, especially when the tumor is present since a long time. Rhinosporidiosis can rarely coexist with long-standing angiofibromas of the eyelid. Complete careful surgical resection of the angiofibroma can give good visual and functional outcome to the patient. The case highlights the complexity of diagnosis and management of this rare combination of pathology, emphasizing the need of careful treatment planning. Thank you.
Thank you, doctor. So did you consider the possibility of preoperatively embolizing the vessels? You saw there were dilated vessels.
They were ligated with suture.
During
they were
surgery.
hugely dilated vessels.
You didn't do a DSA and just evaluate before the surgery?
No.
Okay, what was the cause of diminished vision in your case? Like before surgery, it was hand movement.
It was counting finger 2 meter
and
due
after
to
surgery, the vision improved to 6/24.
because that hanging mass was dragging the eye and it was covering the upper eyelid was covering the visual axis.
So you couldn't retract the lid because of the mass before the surgery?
It was slightly retractable and the other anterior segment was within normal limit.
Are there any previous case reports like this?
No, there is no such combination of pathology in the literature.
Okay, thank you, doctor.
Thank you, ma'am.
Okay, so we go to the next speaker. The next paper is presented by Dr. Rath. No. Presenting author is Dr. Shruti. Sorry, my mistake.
Shall I start?
Yes, please.
A very good afternoon to one and all. What do we do if a patient presents with severe blepharoptosis with poor levator action, and if we want to correct it with autogenous material with a prolonged effect? Yes, we can either go for frontalis sling with fascia lata or frontalis flap. What is known? It is known that post-operatively there should be good symmetry in the eyelid height. The patient should be happy with his eyelid contour, and there should be minimal post-operative lag of thalamus. While most existing studies limit their outcome to eyelid height and lag of thalamus, eyelid contour symmetry with the fellow eye is vital to aesthetic appearance of the face. Now this led us to compare the outcomes of frontalis sling with autogenous fascia lata and frontalis flap surgery in blepharoptosis using image J-based derived objective measurement. So this was essentially a retrospective review of 41 patients between 2014 to 2024 done at the L.V. Prasad Eye Institute, Bhubaneswar. We included 17 normal volunteers who were representative of all age and gender with no obvious eye asymmetry or eye surgery. So we had a set of 24 patients who underwent the surgery. So they were further grouped into group A who underwent fascia lata and group B who underwent frontalis flap. 10 patients underwent fascia lata and 14 underwent frontalis flap. All the measurements were objectively derived using Image J software, which was freely accessible. Our primary outcome measure was MRD1 and the secondary outcome measure was lag of thalamus and inter-eye nasal bitemporal ratio. Now, what do we mean by this inter-eye nasal bitemporal ratio? So basically, we draw a horizontal line which connects the lateral canthus of both the eyes, a vertical line which passes from the superior limbus onto the center of the pupil. Now, a central common point is located and we measure the eyelid contour from that point to the upper eyelid. So this is done at an interval of 15 degree from nasal to the temporal region. The 90-degree vertical line corresponds to the MRD1. Now moving on to the results, demography of patients showed that 58.54% were males and 41.46% were females. The mean age of normal volunteers were 23.7, the fascia lata group was 17.4 and the frontalis flap was 34.7. Both the group showed significant and comparable improvement in MRD1 after surgery. Moving on to the results on contour symmetry, we see two lines. So we have plotted it on a map. The blue line represents the mean of inter-eye nasal ratio and the black line represents the mean of the inter-eye temporal ratio. So this was plotted for the normal fascia lata group and the frontalis flap group. It was seen that the mean was comparable to the normal range, but there was a lot of variation in the surgical group of both fascia lata and the frontalis flap. Lag of thalamus was worse in the frontalis flap surgery, which was contrary to the usual review of literature, and revision surgeries were more common in fascia lata group. A review of literature had actually shown us that previously a few similar studies were done in order to find out the contour, but was done more for Graves' disease and congenital blepharoptosis, where they had actually used temporal and nasal distances and other third-degree equations. But nobody had ever compared the eyelid contour post-operatively for two commonly done surgeries like frontalis flap and fascia lata. Though our study was limited by a small sample size and retrospective design, and we had considered horizontal corneal diameter to be 11.5 millimeter, yet our study is one of its kind. It compared eyelid symmetry with normal volunteers and reduced subjective bias in outcome. We measured everything objectively, be it the eyelid height in MRD1 and contour. So, and we also found out that lag of thalamus was more in the frontalis flap patients. Thank you so much for your patient listening.
Thank you, doctor. That is a well done study. So this measuring the contour, that was your own, you devised that method, or is
So
it?
ImageJ is basically an open source and a freely available software. So we basically used this ImageJ. We took the standard clinical photograph of our patient and we superimposed a digital protractor. ImageJ was used to objectively find out the MRD1 and the contour. So for the contour, for the nasal side, we kept 15-degree intervals. So for nasal side, it was 0 to 90, 15, 30, 45, and 60. And for the temporal side, it was 75 from 90 to 180. 90-degree was measuring the MRD1, and the other points was measuring the contour of the patient.
And
that is
did
how-
your findings, your scientific findings,
Yeah.
did they correlate with the patient's?
Yes, so the patients whom subjectively who were really happy, had very good, statistically significant results as well.
Okay, that's a good
Where,
study.
where do we get this image protector, and is it customized individual patients?
So this is basically a freely available,
Which one?
The ImageJ. This was introduced by the National University, NHS, and it is available online. It is a freely available Java software online. So this helps us to quantitatively, measure.
Understood.
Yeah.
And it can be customized
Yes,
individually.
yes. You, according to what you have to measure, you want to measure. Thank you.
The next paper is, the next presenter is Dr. Samantha Tanima. Her paper is Eyelids Can Lead the Way, Varied Spectrum of Lid Disorders Presenting at an Apex Eye Institute.
Good afternoon. I'll be speaking on varied spectrum of lid disorders presenting at an Apex Eye Institute. I'll go through introduction, methods and material, results, discussion, conclusion and limitations. Sorry, ma'am, this was not the presentation. This was not the presentation.
Can one of us
It's free
Can help
paper
her out,
2267. 2267 वाला free paper present करना है.
This is also case report. Actually, they should have selected it as a physical question.
Good afternoon. Good afternoon. Good afternoon. I'll be presenting on varied spectrum of the lid disorders presenting at an Apex Institute. I'll go through introduction, methods and material, results, discussion, conclusion and limitations. The eyelids being the outermost structure harbors many histological structures which are prone to nidus of infections as well as benign and neoplastic lesions. Hence, diagnosing such lesions needs understanding of the anatomy of the lids, history, clinical examination, histopathological examination, more so in the suspected malignant cases where diagnostic accuracy cannot be made on the basis of clinical backgrounds only. So the aim and objective of our study was to know the epidemiological pattern of the eyelid lesions presenting in a tertiary care government hospital of Eastern India over a period of 5 years, and also to see the diagnostic accuracy of histopathologically proven eyelid lesions. We included all age group patients with histopathologically proven lesions, and all histopathologically undefined lesions were excluded. The study design was a retrospective as well as prospective one from 2019 to 2024 with a follow-up period of 1 year. We used the examination tools of visual acuity and color vision charting, ocular slit lamp examination, ruler Hertel's transformation test, systemic and radiological examination. A prior approval was sought from the Ethical and Scientific Committee. We classified all the eyelid lesions according to WHO International Histological Classification of Tumors. The result of our study was, out of the total 456 samples, the females comprised of 44.8% and males 51.2%. The benign cases were 70.4% and malignant were 29.6%. For each eyelid lesion, the clinical diagnosis was compared with the final diagnosis. Numerical and categorical data were computed using SSPS, and diagnostic accuracy was calculated using percentage for all subcategories. Among the epidermal tumor, the most common benign was nevus, most common benign lesion was basal cell carcinoma. Among the stromal tumors, we found the most common lesion was xanthelasma and the most common malignant lesion was lymphoma. Among the adnexal tumors in our study, the most common benign was hydrocystoma and that for malignant was sebaceous gland carcinoma. Among the inflammatory and infectious, it was chalazion. So the analysis of the benign lesions showed that out of 321, there was a male preponderance of 66.4%, affecting 15 to 45 years of age group more. Left eye and upper lid was the most common site and lesion types inflammatory one was most common. The most accurately diagnosed lesion in both the age groups as well as all the age groups and both the genders was lesion with a accurate diagnostic accuracy of 98.9%, and the most commonly misdiagnosed lesion was nevus 27%. Age-wise distribution showed that the pediatric age group showed the most common lesion being molluscum contagiosum, with that of in 15 to 45 it was chalazion, in 45 to 65 it was pyogenic granuloma, whereas above 65 it was xanthelasma. Analysis of the malignant lesion showed that out of 75, the gender predisposition was equal in both the genders. Most common age group was 45 to 65, and the most common lesion was sebaceous gland carcinoma. The most accurately diagnosed lesion in all the age groups apart from pediatric and both the gender was sebaceous gland carcinoma with a diagnostic accuracy of 96%, and most commonly misdiagnosed was squamous cell carcinoma with a and the age-wise distribution also showed that the most common lesion in all the age group was sebaceous gland carcinoma, with most of the malignant lesions occurring above the age of 65 apart from melanoma. We compared our studies with that of others and found that in almost all the studies, the most common lesion was benign. In our study, the most common benign lesion was chalazion, whereas in others it was mostly intradermal nevus. In our study, the most common malignant lesion was sebaceous gland carcinoma, whereas in others it was mostly squamous cell carcinoma. The benign lesions in our study was most commonly found in the males, whereas in malignant it had an equal predisposition. This has been attributed to the difference in the lifestyle of the men who are exposed to more sun and habit of smoking. Jahagirdar et al. In their study in 2007 were first to point out the rise in SGC in the Indian subcontinent. Kirsten et al., Diokule et al., and Austell et al. In their study have reported the highest diagnostic accuracy of chalazion to be at almost 99.1%. So to conclude, the knowledge of prevalence and different eyelid lesion in a particular geographical area is important for a correct clinical diagnosis. Geographic location, age, race, skin type, and sun exposure influence the distribution of eyelid lesions. Hence, the sound knowledge about the incidence, distribution, and clinical features helps to achieve a high rate of diagnostic accuracy and lowers the rate of misdiagnosis. The limitation of our study was it had a retrospective design, unicentric study, multiple surgical hands were involved, there was inherent shortcomings of medical record keeping and short period of study. These are some of my references. Thank you.
Thank you, Doctor. So, what new information do you feel your study is helping?
Okay. Ma'am, actually, when we were doing the research and doing the study, we found that in the eastern part of India, not many studies were done. The most studies were done in the southern and the central parts of India. So we wanted to know whether the geographical distribution has any effect on the type of lesions we are seeing in our OPD in day-to-day life. And also we wanted to see whether histopathological examination, how important it is and how many differences or misdiagnoses we were making when we are not doing the histopathological examinations.
So how many of your malignant lesions
Yeah.
were misdiagnosed or thought to be benign?
Yeah, ma'am, they were not much. As I have already said, the limitation was because we had a very short period of study. But I can tell some of the examples. Like we got a case of giant molluscum contagiosum. We thought it to be a giant molluscum contagiosum. It came out to be a squamous cell carcinoma. Also, there was a case of chalazion, which came out to be a case of sebaceous gland carcinoma.
So this is very common.
Yeah.
So did you go back and then read
Yeah,
the
ma'am.
surgery?
We had to do a second sitting surgery in all the cases.
Like in your case, you said most commonly misdiagnosed was nevus. So
Yeah.
what was the, how it was diagnosed? I mean, what was the first diagnosis?
Ma'am, as far as I remember, there was a patient, there was a case of capillary hemangioma in one of the cases. And there was a case of pyogenic granuloma, which we misdiagnosed as nevus. And
I'll suggest if you publish your study, you can do the photographic documentation so that
Yeah.
it can help others.
Sure,
Because
ma'am.
most of
I'll
the time
keep
we
that in mind.
misdiagnose, so if we can, it can be helpful to others.
Sure, ma'am. I'll keep that in mind.
Did you compare the finding of your study with the study which have been done in other part of India?
Yes, ma'am. The studies I have shown
And
have been
how,
done.
like whatever the findings in your, how different it is from the other studies?
Ma'am, as I showed in the studies that I have shown that were done in other parts of the India, not in the eastern parts of India, and I found that in among the benign lesions, in our case it was chalazion or lipogranulomatous lesions, but in other studies it was most commonly intradermal nevus. In our cases it was sebaceous gland carcinoma.
Can you quote some studies with that you have compared the findings of your study?
I have shown in the
Presentation.
yeah, it was there. There are many studies. I've quoted in my presentation, ma'am. Should I show it?
That's, I mean, that's the relevant part, right?
Yes,
To
ma'am.
compare with the others.
So
Yes,
that you can conclude ki, like in eastern part of India this disease is common and why
Yeah.
it is happening.
Yes, ma'am.
Okay, and why in other part of India why that disease is more prevalent.
Yeah, ma'am. Definitely, we need a longer sample size also in these studies.
Okay. All right. Thank you, doctor.
Thank you, ma'am.
The next paper is Dr. Gyan Bhaskar has come? No. Okay. It's Dr. Vani Lakhanpal Parekh. Her paper is on surprises on the eyelid.
Good afternoon, everyone. I'm Dr. Vani Parekh. I'm a general ophthalmologist practicing in Mumbai. My topic is surprises on the eyelid, a reaction to an Ayurvedic treatment. So we had a case of a 71-year-old female. She came with a presentation of swelling on both the eyelids and her face. There was profuse pustular discharge from both eyes, inability to open her eyes. She had a history of cold, congestion, blocked nose since 4 days, watering from both eyes since 4 days. Her past history was she was a known case of rheumatoid arthritis since over 10 years, for which she had been on a certain Ayurvedic treatment for over 2 years. 2 months before the symptoms started, she had gone to a center in Kerala for a very specific treatment. This program was called SBA-BA, Program for Rheumatoid Arthritis. It was science-based, evidence-based Ayurveda. It's very detailed, but summary was like for the first month they cut off dairy, oil, ghee, fruits, coconuts, nuts, fermented foods, and only boiled vegetables were allowed in her diet. In her second month, some form of medicated ghee, details I couldn't get, but she couldn't explain it, but some medicated ghee, she said, it was introduced gradually from 10 ml to 80 ml daily over a month. The third month, she came back to Mumbai. She got a cold, after which, as part of her therapy, she was advised that she is not supposed to have a bath till the symptoms of the cold don't settle. She had a fever of 101 when she came, but on the day of presentation, she was afebrile. She didn't take any paracetamol, she just did cold towel compress. And HGT was 173, otherwise general parameters were normal. On ocular examination, pustular discharge, necrotic, erosive patches in areas of the eyelids, inability to open eyes. On forceful opening, the bedside vision was counting finger 3 meter. Pupils were round, regular, reactive, anterior chamber normal, lens seemed clear. This was a presentation when she had come. CT brain and orbit showed extensive diffuse soft tissue edema seen in bilateral, periorbital, and preseptal soft tissue, likely representing diffuse inflammation. No localized fluid collection seen, no intraorbital soft tissue fluid collection seen. The extraocular muscles were normal, orbital walls were intact and appeared normal, no intracranial abnormality seen. Paranasal sinuses CT showed moderate inflammatory soft tissue secretion seen in bilateral maxillary and ethmoid sinuses with soft tissue plugging of right osteomeatal unit. Minimal inflammatory mucosal thickening seen in the right frontal and bilateral sphenoid sinuses. Left frontal sinus was hypoplastic. Osteomeatal unit of left maxillary sinus patent. Bony sinus and orbital walls intact. No soft tissue mass or bony erosion seen. Nasal septum was deviated to the right side and nasal turbinates normal. Cultural swab was suggestive of Streptococcus and Staph aureus, negative for fungal. In the emergency when she had come, the RMOs there gave injection Monosef before calling the opthal. And then after she got admitted, there was an intensivist involved, I was involved, there was a dermatologist involved. So we gave injection vancomycin, 1 gram stat, followed by 500 mg. Injection fluconazole 40 mg. This was before the swab tested negative for fungal. A combination of meropenem and sulbactam. Moxiflox eye drops hourly, Natamet eye drops 6 times for 3 days before we knew it was negative for fungal. Chimoral 4 TDS, Levocet M and ENT had suggested. The dermat suggested a T-bag cream and put Gelonet dressings and also gave linezolid. So this is on the 4th day of presentation. This was after 1 week. In the OPD on slit lamp, we saw thick hyperkeratotic crust. This is 1 week after her admission with erosive lesions over the upper eyelid. After a week, when we actually saw her vision was 6/9 and 8 when she was able to open. Early cataract, cornea was clear, fundus 0.5 cupping. This was 2nd week. By now she was discharged. She used to come for follow-ups. This is between week 2, week 3. And over time, by week 7, she was near normal presentation. So initially I was, since I'd never seen a case like this before, I was assuming was it an odd case of orbital cellulitis, but I'm closer to believing it was necrotizing fasciitis. So yeah, thank you.
Thank you, doctor. That was quite an interesting case. So in her recovery time, was she still on the...
No, of course not. Because immediately when she came, the first thing we said is stop everything.
Yeah.
And her family members were also against it in the first place. Like, so everyone talked her out of it right away. So, yeah.
So the picture that you showed, that was her presentation? Or
that was her presentation, the first picture. So she delayed for 4 days before coming.
She already had the symptom, but she delayed?
Yes, she delayed it. So,
what
4 days. This was in 4 days, she said this happened.
So what do you think was the cause? Why did this happen?
So I am not sure I have still not been able to figure out what was it. Was it the not having a bath for a week and not washing her face at all? Was it the oils that were given, or
so any literature that you looked up which had similar cases?
I did not similar. I found cases of necrotizing fasciitis which was similar but extreme to the point of enucleation done or a fasciotomy done in certain cases. Everything I read up showed that surgical involvement was there. This just a little bit of debridement and IV medication cleared up. So
you should have just included whatever literature that you have, so that we can compare.
Yes.
There has to be a learning from every
yes,
case,
that's
right?
true. Yes,
so we should be able to...
you should have added that.
Yeah.
So what was the final diagnosis in your case?
I believe it was necrotizing fasciitis because it looks closer to that than...
blood culture, anything?
Blood culture showed, no, blood culture, nothing specific as such. WBC count was high. I should have added that as well. The WBCs were high. Otherwise, CBC was normal.
And did they blood culture kiya hoga? Any
no. Just a swab was done. Blood culture as such not done.
So we are giving the top line antibiotics. We should at least try to look for the organism and what is it sensitive to.
Yeah, that's true, madam. There is a program going on in India and across the world, antibiotic stewardship program. We should not jump into higher antibiotics
That
until
is
and
true.
unless proved otherwise.
That is
So
true.
we should always go for a culture sensitivity report. So you should always take a material from the involved site and then wait for the result and then start.
So
the same.
here I have to say the patient was, in spite of everything, was not primarily under my care. He was under a physician. She was
No
under.
excuse, madam.
Yeah, I agree. sir.
I mean, we can still guide, na? If you've been
Yes,
called in for
that's
an
true,
opinion,
that's
you
true.
must give
He
your
was
opinion.
a very senior intensivist, and I was just doing my bit there in the hospital. But yes, you're right.
You cannot say intensivist is above ophthalmologist.
Ophthalmologist,
Okay? We're all
yes,
there
yes.
at par. And, okay. So,
Thank you, doctor. Now I invite the next speaker, Dr. Bobby. He's there. If he is not there, then I call upon Dr. Vasala Vijay. She'll be present. She's there. She's also not there? No. Okay. So, next speaker is Dr. Abhishek Chandra. She's there, Abhishek Chandra.
who's resident?
Dr. Abhishek Chandra.
You'll be presenting? Okay.
So, she'll be presenting on long-term results of adjustable frontally suspension surgery for various types of ptosis.
Not one missing. Doctor, tell us your name.
Dr. Ratnali.
Speak into the mic.
Ratnali Gandhi. Good. Should I start? Good afternoon. Today my topic is long-term result of adjustable frontalis suspension surgery for various types of ptosis. Surgical management of ptosis still remains a challenge even for the expert oculoplastic surgeons. Accurate prediction of eyelid height from frontalis suspension surgery is difficult to assess at the end of surgery. Even after all calculations, undercorrection or overcorrection is quite common. Reasons for not achieving desired effects are effect of local and general anesthesia, patient lying in supine position, lid swelling, anxiety of patient in operation theatre. To describe, the aim was to describe and evaluate the long-term results of the technique, Chandra's adjustable frontalis suspension technique that corrects ptosis on first post-operative day, ensuring desired lid margin height. It was a retrospective study. A total of 182 eyes were operated, and out of them 160 eyes who have followed up of minimum 1 year were taken in this study. The study was performed in the Department of Ophthalmology, Banaras Hindu University and Chandra Eye Care, Varanasi between July 2007 and June 2022. The cases included were congenital ptosis, blepharophimosis syndrome, traumatic ptosis, third nerve palsy, ptosis in myasthenia gravis, chronic progressive external ophthalmoplegia, Marcus-Gunn jaw winking phenomena, aponeurotic ptosis, acquired ptosis after tumor resection. A routine frontalis suspension sling surgery was performed using silicone rod by Fox Pentagon method under local anesthesia. A needle was passed from the superior incision in the anti-clockwise direction through the brow and the tarsal incisions and came out through the superior incision again. The ends of silicone rod at the apex incision were passed to the Watzke sleeve provided with orosling in a crisscross pattern. The needle thus coming out from the temporal brow incision after passing through the Watzke sleeve now lies nasally, and the other needle through the nasal brow incision lies temporally. The end of the first emerging needle was then again passed subcutaneously deep through the initial pass such that the needle came out through the nasal brow opening. Similarly, the other needle was passed subcutaneously to emerge through the temporal brow incision. So these are the images. Now, it was seen that as the silicon rod was pulled, the lid got elevated. No attempt was made to elevate the lid on table. All the 3 superior incisions were sutured. Frost suture to the lower lid was not given as the eyelids were not raised on the table. The eye was patched. On first post-operative day, the ends of silicon rod were pulled gently. As the end were pulled, the upper lid got elevated. The silicon rods were pulled and trimmed closely to brow incision when the lid margin was approximately 2 mm from the upper limbus, or same as the other eye if the other eye was not ptotic. The ends of the silicon rod retracted and went deep in the wound. So these. Results were, at the end of 1 year after surgery, desired lid height was achieved in 152 of 160 eyes. Till the completion of the study, 136 eyes achieved good elevation and did not require any further surgery. Resurgery was required in 16 patients, 1 month to about 10 years follow-up. 8 patients had mild ptosis, but they did not give their consent for any further surgery. So the majority, like 12.5%, were undercorrected, that is 20 number of eyes. Advantages are adjustment done without the effect of LA or GA, without any lid swelling, in sitting position with both eye open, in consultant's chamber, can be adjusted at later date, 1 week to 10 years. Temporal and nasal lifting can also be done. Adjustable frontalis suspension surgery is an effective method in the management of congenital and acquired ptosis. The cosmesis obtained is much more superior as compared to the conventional Singh surgery. Thank you.
Thank you, doctor. Are you a part of the study? Because your name isn't anywhere on the list.
I'm in the first year resident.
Okay, so we've allowed you to present, but then it will not be considered as competitive because you're not even one of the co-authors. Yeah, it's an interesting study. I wish the main author was here. You did not even tighten on the table. Everything was okay, just to see it, or you don't know?
Post-op, when the patient came in the OP.
No, I'm saying intra-op. Intra-op, we usually tighten it once to see have we got everything okay.
In this procedure, intra-op, we don't pull the string, but...
No, I've understood that. But when we pass it, normally during surgery, we just check the contour once. So they were so confident they didn't even need to check the contour. Good. All right.
Okay, thank you, doctor.
Thank you.
Okay, so has any of the people, I'm just going to give one chance more for those who's missed their turn. Dr. Raguraj Hegde is here? No. And Dr. Nipun Kumar? So she's presented, but it's not competitive. She'll not get marked down. So it's not being considered, no? It's not being considered. Just since she's a first year resident who has just come here, we just gave her a chance to speak. Dr. Nipun Kumar, Dr. Gyan, Dr. Sarungbam Bobby. Okay, all right. So the last speaker was just allowed to present, but it is non-competitive. Okay. So yeah, thank you all. Some of your studies were really very good, and I just feel that the residents should understand that The free paper is for, we want to all learn something from your free paper. There should always be a message that is coming out of the study, even if sometimes the duration is less, the number of cases is less. There should always be a message, something more for all of us to learn, to, a direction to go forward. And though the single case reports are really interesting, but they don't really fit into sort of the free paper, because there's not a whole lot we can learn from just a single case. So thank you all for your presentations, and I think the results are announced later. And yes, we can have all the presenters for a group photo. We can actually just have everybody who's here for a group photo. It's a big hall.